Medical Association. I'd like to welcome you all to the third in a series of Foster Healthy Weight and Youth webinars that will focus on the impact of childhood obesity on bones, joints, and muscles. We'd first like to thank Dr. Carla Lester with Teach a Kid to Fish and the NMA's Childhood Obesity Prevention Project, Holly Dingman with the Department of Health and Human Services Nutrition and Activity for Health Program, Dr. Christina Fernandez with Creighton University Children's Physicians, Dr. Sally O'Neill and Jeff Klein at Creighton University CME, and Dr. Paula Esposito with UNMC's Children's Hospital and Medical Center for all the work they've done to make this webinar possible. I'd like to introduce Dr. Carla Lester, who will talk about the CME credits associated with this webinar and will give the background of the Foster Healthy Weight and Youth model. Dr. Lester is a pediatrician here in Lincoln that started a nonprofit organization called Teach a Kid to Fish. Its mission is to prevent and reduce childhood obesity by empowering Lincoln children and families to eat healthy and be active. Dr. Lester also developed the NMA's Childhood Obesity Prevention Project. Dr. Lester?
Thank you, Tammy, and thank you all of you for joining us today. And a special thanks to Dr. Esposito. I just want to remind you that the Creighton University School of Medicine designates this live and enduring material activity for a maximum of 1 AMA Category 1 credit. And a detailed information sheet containing this information accompanied this webinar registration and may also be found on the Creighton CME website. After the webinar, you will be sent a link to the post-test and evaluation via email, and you may also visit cme.creighton.edu for more information. This activity has been planned and implemented in accordance with the essential areas and policies of the Accreditation Council for Continuing Medical Education through the joint sponsorship of Creighton University School of Medicine, the Nebraska Medical Association, Teach a Kid to Fish, and the Nebraska Department of Health and Human Services. Neither the planning committee or speakers for the webinar series have any conflicts of interest or disclosures and have signed statements claiming as such. I want to remind you again about Foster Healthy Weight and Youth. It's Nebraska's clinical childhood obesity model. The clinical resources have been and continue to be disseminated to physicians across the state. It's a comprehensive model with toolkit, pocket reference algorithm, free CME training video which outlines the steps in assessment, prevention, and treatment in the primary care setting. There are also consistent messaging, patient brochures, and posters with which to resource your office. All of the resources are free and are available through the NMA Childhood Obesity Prevention Project website. The objectives of today's Foster Healthy Weight and Youth webinar are to describe the orthopedic comorbidities of childhood obesity, describe the clinical presentation of those comorbidities, and explain the etiology of those complications, and then describe future directions for the management of the orthopedic complications of obesity in children. Thanks, Tammy.
Thanks, Dr. Lester. Today's webinar is titled Pay Now and Pay Later, the Impact of Childhood Obesity on Bones, Joints, and Muscles. Our speaker today is Dr. Paula Esposito. Dr. Esposito is a professor of orthopedic surgery and pediatrics at University of Nebraska College of Medicine. He received his medical degree from Heinemann Medical College and Hospital. He completed his internship and residency in orthopedic surgery at the U.S. Naval Hospital in Oakland, California, and a pediatric orthopedic fellowship at Children's Hospital Medical Center, Cincinnati. Dr. Esposito serves as a representative to the U.S. Bone and Joint Decade Committee for the American Academy of Pediatrics, a national organization dedicated to increasing awareness of bone, joint conditions, and disease. He has had several publications and national presentations. Dr. Esposito?
Thank you, Tammy. It's a pleasure to be here and an honor to be able to work with such a fine organization. Having been involved in this at a national level, I can tell you that Nebraska is, I think, ahead of the curve in terms of the efforts that are being undertaken. And I'm also having a little bit of a WKRP in Cincinnati moment here, trying to sort out this webinar thing, but I'll do my best to make this interesting for you. I have no conflicts of interest, and I don't own any Burger King franchises, so I think I can talk on this reasonably well. Childhood obesity, as you're all aware, is associated with metabolic conditions that are very well recognized. The incidence of diabetes, for example, is just exploding, but the impact of childhood obesity on musculoskeletal growth and development has really not been looked at all that well. When we met as the U.S. Bone and Joint Decade, which is an organization of organizations, including dietetics, occupational therapy, physical therapy, the spectrum of medicine and chiropractic, universally at an international level came out that obesity is one of the biggest musculoskeletal issues there are. We know that in the last 15 to 20 years, there's been a significant increase in the incidence of slip capital femoral epiphysis, which is something we traditionally saw in children about age 12 or 13, typically associated with obesity, Blount's disease, which is a progressive bowing that we see either in children in the infantile form or in adolescents in the adolescent form. But there's also an increase in back pain, even an increase in fracture rate related to obesity. And poor bone density, which is a complex issue related not only to their weight, but also perhaps to diet and activity level. And then chronic joint pain. We know that childhood disorders can lead to adult degenerative changes. Clearly, people who have developmental hip dysplasia or congenital dislocation of the hip can develop early arthritis. And we see that in these childhood disorders, even when the kids are teenagers, there are times when people have significant degenerative arthritis even before the age of 20. So it's important to try and prevent childhood disorders of joints and bones that could lead to adult disease. But there's little ongoing research on the long-term impact of obesity and related childhood musculoskeletal disorders, and that's one of the efforts that we're trying to make, not only through the U.S. Bone and Joint Decade, the American Academy of Pediatrics, and all the other healthcare organizations. The other thing about obesity in terms of musculoskeletal impact is it's harder to run and play when you're obese. It interferes with a child's ability to perform healthy physical activity, and if you can't do healthy physical activity, it's hard to maintain a healthy lifestyle and not put on weight. And it's a vicious cycle. There's a number of organizations that have excellent data. You know, I'm just picking a few here. The American Academy of Orthopedic Surgeons, which is near and dear to my heart, has some wonderful materials that are also available and talks a bit about musculoskeletal impact, but mostly the fact that obesity interferes with a healthy lifestyle. And obviously the American Academy of Pediatrics is another organization with a major effort in conjunction with the First Lady, Mrs. Obama. But it's a worldwide scope of a problem. It's most profound in economically developed countries and urbanized populations where a lot of calories are easy to come by. But you see the same type of metabolic problems, the same type of musculoskeletal problems in Europe, the U.S., China, and around the world. Now, the only places in the world where the incidence of these problems of obesity have gone down have been in Russia and Poland. They're the only ones I could find reported in the literature. It's essentially increased in all other parts of the world. And phenomenally, in Africa, some parts of Africa, it's becoming more of an issue than malnutrition. And there's a large discrepancy between groups, ethnic groups in this country, with the highest incidence of obesity amongst Native Americans and Alaska Natives, with Hispanics coming next, and then whites, Asian Pacifics, and African American children. The problem with many of these groups is the availability of healthy foods and access to safe recreational facilities and programs are a major issue. And that's one of the emphasis we discussed at the U.S. Bone and Joint Decade was how do we get the community involved to provide safe places for kids to be kids and to play and be active. Again, the highest incidence is in the southeast, lowest in the Rocky Mountain states, and in the upper Midwest we're not the highest, but we're certainly not where we want to be. Key part of obesity in terms of musculoskeletal health is in the healthy bone mass. There's been a great deal of interest, obviously, in osteoporosis in children and its implications. And here at Children's Hospital Medical Center, we have a very active osteoporosis and brittle bone disease program, metabolic bone disease, and we've noticed that this is interfering with the children we see now have a much better chance of having poor bone mass, poor vitamin D levels than any time in the past. The key to bone health and the key to bone mass is in building it up during the pubertal skeletal growth period. And you have to have adequate physical activity and proper nutrition to develop optimal bone mass. When we look at vitamin D levels now and calcium levels, they're low compared to what it was historically. And so when you really look closely at children, especially obese children, vitamin D levels are low enough to have at least some mild bone health effects. There's also some thyroid hormone dysregulation. It's not normal to just sit still as a child. And the diet is important, obviously, to make sure you have adequate calcium and vitamin D, but there's a lot of evidence that the stronger role is the level of activity rather than the diet. So sedentary lifestyle is increasing. Preschoolers, for example, are spending more time with TV than ever, and there's a smaller gain in bone mass in this age group now than ever in the past. So we know that exercise is crucial to bone mass, but also to lean muscle mass is crucial. Exercise programs have to promote success and not pain and frustration. Telling a kid to go out in the springtime and run the mile when they haven't run for 2 years makes not a lot of sense. We need to work and develop programs that allow the child to succeed and gradually improve and see progress. There's some weight resistance programs, for example, where you can have relatively light weights, let the child see that they're successful in improving, gaining strength, and improving every day, that can get them into the idea that exercise can be fun and you can see progress and improvement. But one thing that's clear is that you can't combat obesity without increasing physical activity. Now, calcium is 99% in the skeleton, and you have a continuous resorption without replacement leads to decreased bone density. So we need to be careful and make sure that our kids are getting adequate calcium. We're not seeing as much milk drinking, for example, so we need to make sure that they are getting it. There's some excellent guidelines. I'd like everyone to be aware of this one by Abrams in the Journal of Pediatrics that just came out a few months ago. It has very nice recommendations. Now, whether or not this is the final answer or not, I'm not 100% sure. I think we probably need to be giving the kids even more calcium and vitamin D than what they recommend here. But this is a nice start, and it's been the first clean look at vitamin D and calcium in a little while. So recently, the American Academy of Pediatrics increased the recommendation for vitamin D, that we need to make sure kids get at least 400 units from 0 to 12, 600 units over 1 year. But the maximum amount varies when you look in the literature about what to recommend. The key thing is to in your practice, in your own families, make sure that they're getting enough. When we looked at the vitamin D levels in our area, most of the kids are below 30, 70 to 80% of the kids we see. And that's across ethnic groups, it's across racial groups. So there's something missing in our diet as well as our sun exposure. People often ask about the role of sodas in diet, and you need phosphorus to form hydroxyapatite in bone. You need that scaffolding to develop good, strong bones. And carbonated beverages are high in phosphoric acid, and they have been shown in females at least to increase the fracture rate, but not clearly and definitively in males. The other thing is sodas tend to displace calcium and phosphorus intake. Kids are drinking pop instead of milk, and they also tend to contribute to obesity because of the increased calories in these high sucrose drinks. Magnesium, on the other hand, you need in your skeleton, but it's usually not caused by dietary deficiency. It can be seen in some malabsorption syndromes and protein deficiency diets, but also in Africa is one of the few places where it can be deficient. So when we look at obesity, obviously we just talked about the necessity of developing good, strong bone mass, good, strong muscles. To avoid fractures, you need to have good balance, good bone strength, good muscle control. So in the last 10 to 20 years, there's been noted to be an increased risk of distal radius and forearm fractures, and the exact cause isn't known. We think it may have something to do with decreased activity, decreased bone acquisition from diet. There's some suggestion that you might be able to modify some of these activities and these factors to decrease the rates. Obviously in playgrounds, we've made a great effort to make sure there's good soft surfaces with absorbency underneath the playground equipment. That's clearly been shown to improve and decrease fracture rates. But perhaps just getting control of the weight, getting control of the muscles, getting the kids toned up again will decrease those rates of fracture. In obese children, they think that part of the problem is that they don't have very good balance. They have trouble with proprioception and balance because they don't have good muscle strength relative to their weight. Their lower extremity malalignment occurs. The kids are either going to be really bow-legged or really knock-kneed. Some of the kids, especially when you look at adolescents, have trouble putting their thighs together because their legs are so big. And this contributes to more of a knock-knee posture. Their body habitus, they're as wide as they are tall, tend to tip over better and easier. And then they have a relatively low bone mass and area for weight than their peers do. So not only do kids with obesity have a higher rate of fractures, they also have a higher complication rate. We as surgeons really don't like doing any operations on them for a number of reasons, but they're out of Baltimore. They've clearly been shown to have a higher rate of deep vein thrombophlebitis, decubiti, and they're more difficult to treat successfully, both operatively and non-operatively. They have an increased risk of anesthesia, aspiration, airway problems. The hardware we use in children are small. Obviously, when we use plates and screws, they're designed for small bones. These kids, their bones are small, but they're supporting a lot more mass and weight. So the failure of the devices is also a risk. We're more likely to have to operate on a heavier kid because we can't use cast immobilization because of the shape of the child. If you try and put a cast on a barrel, it just tends to slide off. And again, these kids have a very difficult time walking on a regular basis. If you put a long cast on their leg and then give them crutches, they have even more difficulties. They also have pain in other areas. The most common sites of just pain on a daily basis for these kids is back pain in almost 40%, foot pain, knee pain. The foot pain can be either just from them putting all their weight on their ligaments and stretching things out. It can be contributed to because they also have knock knees, which puts more strain on the medial side of the foot. And the knee pain, that can be for a variety of reasons. Again, the knock knees, kneecap pain, things of that sort. They've been shown that the kids with a higher BMI have more pain in the back than kids who don't. 45% of obese kids had back or lower extremity pain in that study. Even ankle injuries, very commonly kids will injure the growth plate on the outside of their ankle, for example, right there. And typically we just treat the kids with a brace for about 4 weeks and they go about their business. When they looked at this at Children's Hospital of Cincinnati in the last year or two, they found that there's a 44% greater chance that these kids are still going to be hurting 6 months later. And again, if you have chronic pain, it's much more difficult to motivate yourself to go out and exercise. Now, the alignment can be a major issue too, and it can be a major issue when you're an infant, a toddler. It can be a major incident whenever you become an adolescent. We know that genu varum is a normal thing. Most kids have bow legs until they're about 18 months of age. But in some children, especially obese children that walk early, they can get progressively more bows. And we're going to look at that again in a few minutes. But when the kids have this pattern here, and they come in and they say their kid's getting more bow-legged, we always get a standing x-ray, and you can see that literally this growth plate, instead of being parallel to the ground, is downsloping on the medial side. So this child is literally beating the dickens out of their growth plate, slowing the growth down because growth slows whenever it's compressed, and you have a progressive bowing. These kids also have a tendency to turn their hips out, so that puts more strain on their hips. When you look at a child with morbid obesity, this is a pretty common standard scenario, to the point where when this child would walk into my office, my secretary at the front desk would tell me we have another one of those kids there with a slipped epiphysis, because they all have this external rotation, knock knees because they can't get their thighs together, and they have pain. And most of the time, clinically, these kids will have pain along their medial knee and medial thigh, because that's where the obturator nerve goes from the hip to the medial thigh, is where that pain distribution is. So when we see kids with pain in the medial thigh that look like this child, age 11 or 12, or even much younger now, we know that they have a higher risk of slipped epiphysis. So again, they come in with a limp and trauma. And the one pearl for the day is, especially with these heavy kids, is that kids do not get muscle strains. It just doesn't happen, with rare exception. So we see a child that's limping more than a day or two, or is having consistent pain. They really ought to be evaluated by someone who's used to looking at the musculoskeletal system in children. The average time to diagnosis for a child with slipped capital femoral epiphysis which basically means that the femoral head slides off of the shaft of the bone of the femur, is about 3 months. The longer it goes, the more it slips, the more consequences there are. And again, the incidence is pretty amazing. It's increasing now. From 1997 to 2000, it was 10.8 cases per 100,000, much higher in African Americans, much higher in Hispanics than in white kids. And there are geographic differences in lower ages of presentation. So it's much more common to see a child in Mississippi with a slipped capital femoral epiphysis than it is up here in the north. Again, it's much more common in African American kids, but we're seeing it more commonly in other kids too, regardless of ethnic background. So we know the slipped capital femoral epiphysis, and this is the femoral head, and you can see that it should be sitting up here on the femoral neck, but it's slid off. So this is what's called a pistol grip, like the old percussion pistols that they had in the pirate days. That femoral head's literally slipped off the femoral neck. We know that this is happening at a very young bone age, and children are maturing at a younger age. So instead of seeing it now in 11 and 12-year-old girls, we're seeing it in 9 and 10-year-old girls. And instead of at 13 and 14-year-old boys, we're seeing it at 11 and 12-year-old boys. So this is a very major issue. And the other thing that we're aware of is that being overweight may cause you to mature earlier. Now, you know, there's proof that this is happening at ever more frequency. The rate in New Mexico doubled from the 1960s to 2008, and the rate of obesity in that state has tripled since that same time frame. But it's not just in the United States. It's a 2.5 times increase in Scotland over these 2 decades, and the kids there are also showing up at a younger age. So when we see kids that limp at a very young age, even age 9, 10, 11 now, this is a very common thing. So medial thigh pain in a child who's obese especially makes us very suspicious for this slipped capital femoral epiphysis. We're also seeing kids under the age of 8 years, which used to be unheard of. It used to be only the kids that had irradiation for gonadal tumors or who were hypothyroid would have a slip under the age of 10. But we're seeing this now in kids. But most of you who are interested in this area know that we're seeing kids that have body mass indices over 30% for age at age 5 and 6 and 7. I have personally seen a child that had a Blount's disease at age 4, slipped epiphysis at age 6, and a spondylolysis at age 10, all related to obesity in the same child. And that used to be almost unheard of. So we know that slipped capital femoral epiphysis is related to hypothyroidism, as we talked about, but there's absolutely no evidence that it's related to any increase in endocrine disease now. We know that in kids with hypothyroidism, that once they're treated with thyroid hormone, they rarely have a slip. Growth hormone deficiency, too, again, has not been clearly associated with it. So the major factor at this point is obesity and slipped epiphysis. Now, this is important, too, in kids under the age of 10, because this in the older kids will happen about 35 to 40% of the time in both sides, but the younger you are, the more likely it is to be bilateral, up to 61%. So when we see kids under the age of 10, we now routinely put screws in both of their hips to keep them from progressing. Again, the other major deformity we'll see in kids, especially the toddlers, is bowing. And probably the key thing for everyone to know is that the kids normally are bow-legged until 12 to 18 months of age, but no child should ever be getting more bow-legged. If any mother comes in and tells me that their child's more bow-legged, I automatically get a standing x-ray of their legs. And I do that, an AP x-ray from the hips to the ankles, because you'll literally be able to tell, does the child have rickets, which is another thing that is not necessarily related to obesity but can cause progressive bowing, and is a vitamin D disease, and is the child falling off the growth chart? A child with progressive bowing has either rickets or some type of metabolic disease. Now, the key thing is that a normal child will have bowing both at the thigh bone and the shin. In Blount's disease, which is the growth plate compression problem in obese kids, their angulation is all right below the knee in the proximal tibia. And they'll come in and tell you they hurt. And little children never tell you they hurt. If they say they hurt consistently and it's preventing them from playing, they've got a significant problem. again, if you develop your obesity when you're bow-legged, you're more likely to get more bowed. But if you happen to be after 18 months and then become obese, you're more likely to get progressive knock knees. And one of the things you can do to say, is this getting worse, is to, in knock knees, put their knees together and measure the distance between their ankles. And in bow legs, put their ankles together and measure the distance between their knees. And typically, this is less than 10 centimeters. I put degrees on the slide, and I apologize. It's actually 10 centimeters. So clearly, obesity alters the way you walk. It alters the stresses you put on your joints. The long-term implications are unclear, but we're clearly concerned that many children are already having pain in the malalignment at an ever younger age. We're seeing the adolescent Blount's disease again when the kids are 8 or 9, not when they're 12, 13, 14. And it's important to pick these things up early and show the parents the impact that their diseases are having on them, that the obesity is having on their joints. With that varus loading of the knee with the bow legs, you put pressure on this side. Early on, the kids we can treat with bracing, but after it's fixed and established, they require osteotomies. So these kids, just because of their obesity, can cause themselves to have very significant operative procedures and still end up with degenerative arthritis later on. If we pick up the bowing early, you can see this is a fairly normal growth plate here. This one's starting to downslope, and you can see where the shin is going. We can literally guide the growth by putting either staples or plates on the outside and allowing the leg to correct itself. So early diagnosis can really allow for some very minimal type of surgery that will allow for maximum benefits and long-term prevent arthritis. Most people with degenerative arthritis as adults have bow legs. It's very rare to have a worn-out knee with a bit of a knock knee. That being said, there's a subgroup of kids who do develop progressive knock knees as teenagers or adolescents. They have pain on the inside of their shins, inside of their feet. If you look at this ankle, it's tilted out. Normally it tilts out 5 or 6 degrees. This is a good 15 or 20. You can see instead of being parallel to the ground, these knees are tilted out. Now, again, if you find it early, you can use a similar sort of stapling or plating to guide the growth back. But late, you have to do osteotomies, which is a major undertaking in an adolescent. And again, this child is a 16-year-old young lady that had a BMI of about 32. Already has spurring on the outside of her knee. She's already has some cysts forming on the outside of the knee. And this is something you would typically see in some 50 or 60-year-old who's starting to develop degenerative arthritis. So at age 16, there's already a significant degenerative problem. And again, why would they have ankle pain and knee pain just because they're obese and they can't get their thighs together? Well, they put a lot of extra stress on the inside of their ankles because their ankles are tilted so much. So this child, to prevent her from having arthritis and to get rid of her pain, underwent an osteotomy. And this is a good 8 to 9 inch incision. We basically cut the femur in two, put a wedge in to correct the alignment, plate it back together again. And then the child has 3 to 4 months of rehab and healing to go through. So ideally, we find these things early, and if we can't modify their weight, modify their activities to prevent the damage they're doing, at least do an easier way when to take advantage of their growth and do a stapling or a plating rather than have to do these osteotomies. So this is a study out of the DuPont Institute a few years ago. They found that the kids with the highest BMI, average of 40, tended to get Blount's disease. They tended to pound the growth plate of their knee the most. And this is a study looking to see, do any of these things cross over and do they happen at the same time? Type 2 diabetes, the kids tend to be in the 35th BMI, 35%. Slip capital femoral epiphysis, a little bit lighter, if you want to call that light. And there's no overlap of disease. None of these kids had Blount's and diabetes and slip epiphyses at the same time. So what are we going to do in the future now? Because the higher rate of pain and deformity and fractures makes an active lifestyle difficult. And then the other side of the coin is that you can't combat obesity without being physically active. And we know that the long term, these individuals will be at further risk of premature degenerative musculoskeletal disease. We need to look closer at the role of vitamin D. Can it be preventative? Are we giving the kids enough? And that's just now starting to be defined. It clearly needs some more study and potential medical and governmental input. There is a Kelly Leach in Canada, for example, has gotten the Canadian government to give tax breaks to people who enroll their kids in after-school physical activity programs through the YMCA. So we need to continue trying to coordinate the efforts of children, parents, schools, communities, and social and sports organizations to develop activities so all kids can participate at a comfortable level. We know that intervention in childhood will clearly have an impact for a lifetime. There's a number of resources. One the Bone and Joint Decade is doing is a PB&J is a program for teenagers, a resource for fitness and healthy lifestyle that I think would augment the efforts that are happening here in our own state. And the U.S. Bone and Joint Decade also has a book out on the burden of musculoskeletal disease, which provides a lot of information that can be beneficial when we're advocating with our legislators. And I'd like to end my discussion, my talk right now, and be more than happy to take any questions.
Thank you, Dr. Esposito. Let me get this open here. We'll now open the webinar to any questions that you have. Again, you can type your questions in that questions or chat section to the right of your screen, or you can press the raise your hand button and we will unmute your line. We'll take just a couple minutes here and let people
Dr. Esposito, thank you for your talk. This is Carla Lester. It was very helpful. I wanted to know, what do you recommend doing for those kids with the chronic pain? If you work them up, they don't have any fractures or underlying pathology, and they're just kind of walking around with chronic pain. Does physical therapy help them? Or?
Yeah, Dr. Lester, I think, that brings up the whole summation of everything. They hurt because they're obese. They can't quit being obese because they can't be physically active. I think we have to look at them as holistically as we can. Physical therapy can be helpful in terms of defining programs for the kids to get involved in. What kind of exercise can they do to be successful to allow them to become more active? I think we're at a little bit of a disadvantage here in the Great North in that we can't just have kids get in the swimming pool all year round, although some of our communities have indoor pools. But I think developing a therapist's main role would, in my mind, be to help guide them into activities they can do comfortably and safely so that they get rid of the obesity and they get rid of the pain.
Okay, thank you.
Dr. Rauner, do you have a question?
Yeah, Paul, this is Bob Rauner. It almost seems like there's almost a point of no return where a kid's obese for a certain length. You're never going to be able to reverse a lot of things. And that almost kind of brings to mind that you almost have to start doing things in kindergarten through 5th grade or even earlier to really get them active sooner. And that means schools. Any advice in that area?
I think, Bob, you need to start in a crib because some of these kids are so well established by the time they're 2 or 3. I mean, we're seeing kids now that are 40 and 50 pounds at age 2 who are having Blount's disease, for example. I don't have the answer for the schools, obviously. My role, I think, here is to just bring to everybody's attention that these are lifetime things they're developing, and I think you're absolutely right. You can get to a point where they're irreversible. We have had some success, with the HEROES program here at Children's, for example, and getting the kids to say, I want to make this commitment, and the families to say, I want to make this commitment. But obviously in your office, my office, it's rare that you don't see everyone in the room who needs to get in the program. It's not, obviously not just the child.
Thanks.
Dr. Rauner, did you have another question?
I know that was it, but I mean, really almost seems like even K through 5 is too late. It's almost early child care, younger.
Very young, very young.
Dr. Esposito, this is Carla Lester again. Do you know of any specific, I mean, you referred to weight resistance and then this PBJ.org program for adolescents, but do you know of any other specific weight resistance programs? I mean, I know it's an issue like for physical education in schools that these kids feel like kind of a vicious cycle of failure, that they can't participate because they can't, you know, reach the goals like the other kids can. But are there any programs or resources for either on a community level or for schools for physical education and dealing with, you know, weight resistance for obese children?
You know, it's a fascinating question. You know, I don't know of any, and I think that's probably an area where we need to, you know, the Bone and Joint Decade, for example, the PTs are well represented there, but we've not directly approached them and said, you know, is there a program developed or should we be developing a program? I think that's one of the organizations we should partner with is the physical education teachers. But even then, we go back to what Dr. Renner was just saying. This happens even before they get to school age.
Mm-hmm. Yeah. Does anyone else have any questions at this time? Okay. We just want to remind you that you will receive 1 hour of continuing education credit for this webinar. You'll receive an email following the webinar that will have the link to the post-test and evaluation. We ask that you complete those so we can make sure that we're meeting your needs, or if there's something else that you'd like to be seeing during the series. We do have 3 left this year. And also we'd like to encourage you to visit the NMA's Childhood Obesity Prevention Project website at www.nedmed.org/COPP.ASPX. If you've missed any of the previous webinars, the prior 2 webinars, I guess, they are on the website as well, that you can go on and receive 1 free hour of CME for those presentations as well. And again, the Foster Healthy Weight and Youth resources, you can also find that materials request form on that same website, or email Holly Dingman here at the Department of Health and Human Services. With that, we just want to thank you all for taking your time and taking the time out of your day to join us for the webinar, and thank you, Dr. Esposito. If you think of anything after the webinar is over, please feel free to contact us at the NMA or Dr. Lester, and we will see if we can answer any of those questions. So thank you all again.
All right, thank you.